So to kick off, our first two speakers will be presenting on the prevention of infection in people with immune compromise. So I'd like to introduce Associate Professor Krispin Hajkowicz first. Krispin is a senior staff specialist in the Infectious Diseases unit at the Royal Brisbane and Women's Hospital and the former director of the unit. He is also a clinician researcher at the University of Queensland Fraser Institute, focusing on clinical metagenomics for novel and emerging virus detection, as well as respiratory virus, phylogenomics and epidemiology. He is also a PhD candidate at the University of Sydney. Please join me in welcoming Krispin to the stage.
Thanks very much, Leanne. Thank you everyone for coming. Great turnout. Lovely to see you here for the ASID conference, and I'm sure we're going to have a great few days. And I get to kick it off, which is super exciting. I have some disclosures there on the screen, so quick look at those. Over the years, when I've been to Therapeutic Guidelines meetings, I've always admired the big senior old people in the room, and suddenly horrifically realised when I was going for these ones that was me, and that I was the one that was really struggling to read the fine print and all that sort of stuff. But it's been a wonderful collaboration for me over the last 10 years. There are collaborations that we hate, like research governance meetings and that's like that. There are some that are just kind of barely okay, but it's just such a fantastic collaboration. It's a wonderful thing to do. In terms of professional development, I couldn't think of a single better use of 15 minutes than sitting in a room with all of these experts arguing about all the stuff for which there isn't good quality clinical trial data or evidence. It's really, really handy. You'll see Bart and Lindsay standing next to each other there, clenching their fists probably. There were some pretty feisty interactions in the day. And I have to say, extremely pleasingly, over the last 10 years, there has been a shift, I think, to much more collegiate discussion, much less controversy. The gender balance has dramatically changed for the better, and it was super pleasing to have lots and lots of non-infectious diseases physicians for our group, from haematology and general practice, respiratory, a whole lot of experts from a whole lot of fields, really well represented. And then, bless them, the poor paediatricians who have to sit through all of the discussions constantly, because there's always a little bit about paediatrics at the end. So it's been great. The other thing is that you get to go down to Melbourne and stay in the Flagstaff Gardens, and it's a great running city. And I mainly put that up there to just humble brag about how I used to be a really fast runner at the times, and just to say that all you Melbourne runners here, you've got it so easy because it's so good running in Melbourne. It's such a great city for it. Okay, I'm going to talk about why immunocompromise is becoming more and more important, and how it's changing pretty dramatically and rapidly at the moment. I'm going to talk about the Therapeutic Guidelines antibiotic chapter update without trying to go into too many specifics. I'm keen to discuss a lot of the challenges I think that there are in implementing guidelines and achieving consensus, and then some conclusions. First up, there are more and more immunocompromised adults than ever. In a survey in the US, roughly 1 in 20 people now have substantial immunosuppression, and there's been a 2.5-fold increase since 2013. I just cannot see this slowing down at all. There are many more, much more specific immune modulators and immunosuppressants that lead to very specific defects in the immune system and very specific infections. That's something that I'm really often struggling with, to be honest. The pathways are ones that we never learnt in med school. They're ones we've never even heard of, so it takes a lot of learning to try and get used to that. Severe immunosuppression secondary to cancer treatment is dramatically more common. I've just put some data up here looking at the huge explosion in allogeneic in blue and autologous in red stem cell transplants since 1990, noticing a bit of a plateauing around COVID. Even more marked is the huge, huge uptake of the CAR therapies shown, no, not shown there, shown on the next slide. With stem cell transplantation, there's been a very big shift to haploidentical transplants, which is massive. It's a great thing if you've got cancer, because it's colossally expanded the pool of donors, and also means that getting a donor match can be done very, very quickly now. That's dependent on post-transplant cyclophosphamide, Hopkins University's brilliant breakthrough, and it means that lots more people can get cured from their cancers, but it does mean even more immunosuppression than ever before. I'll talk a bit more about the CAR therapies. A really important point is that older adults are undergoing a much more immunosuppression than previously. There are many more transplants, much more treatment happening in people who already have immune senescence and are already in a state of relative immune suppression anyway. Sometimes these are approached with reduced intensity conditioning as well, but it is another big merging factor. And then common comorbidities like diabetes mellitus, chronic kidney disease, already states of relative immunosuppression, and again, more and more people are receiving immunosuppression on top of that. Infections in the immunocompromised are often quite hard to diagnose as well. This further compounds the challenge. Rare fastidious pathogens such as Legionella, Nocardia, the non-tuberculous mycobacteria, Mucorales or LCMV are just examples from all three different kingdoms of tricky to diagnose infections, and they'll often occur at atypical sites. And a tip for trainees, if you ever see people with febrile neutropenia and funny-looking blotchy skin lesions, just say that it's a pseudomonal infection of the skin, and you'll get very good kudos for that. With less inflammation, there are often attenuated changes. For example, diagnosing pneumonia on a chest X-ray in someone with severe immunocompromise is very difficult because there may just not be that much inflammation in the lungs. They are also the canaries in the coal mine, and if there are novel, emerging or fastidious pathogens to pick up, they will emerge first in immunocompromised hosts. The changing nature of immunocompromise means that there are new therapies, just constant ballooning new therapies. There are new indications for existing therapies. There are new populations, for example, older people receiving haploidentical transplants for the first time. Are there new pathogens? Look, there almost certainly are. And as a shameless plug, come and see poster 45, where we describe a novel virus emerging in stem cell transplantation in Queensland. All right, what about the therapeutic guidelines antibiotic? There have been a lot of updates and changes to the chapter. It was a very, very complicated task, and it took many, many meetings to get it right, but it's super excellent, and I'm super proud of it and all of the work that my co-collaborators did on it. And it's a really, really useful document that will help you all a lot manage your patients day to day. I've just been on consults, actually, in our haematology ward for the last week, and I've constantly referred to this. I think number one is the renal dose adjustment, actually, for antimicrobials, but I find myself looking at this all the time. All right, the chapter starts about talking about what we can do to prevent infections in immunocompromise. And obviously the first of those is screening and the idea of not proceeding with an immunocompromising therapy if an infection is present. A really good example of that would be detecting Burkholderia sinescipacea in a potential lung transplant recipient where we know the outcomes are far, far inferior and just wouldn't go ahead with the transplant in the first place. Secondary, treatment of latent infection, for example, tuberculosis. Although I understand from the guideline we're not allowed to call it latent tuberculosis anymore, we have to call it asymptomatic tuberculosis. So anyway. Providing immunisation, for example, pneumococcal immunisation prior to an elective splenectomy. Primary prophylaxis is really what we focus on. For example, I think probably arguably one of the most important would be cotrimoxazole for PJP. If in doubt, just give it. And secondary preventative therapy after people have already had an opportunistic infection. And that's really was the main focus of the work that we did. A question that I get all the time, and for which unfortunately there is no answer, but here are a few tips, is what is significant immunosuppression? It's something we've grappled with continually. As I've done this chapter over the years, you can actually always find a single case report of any given infection with any combination of immunosuppression, and you can certainly find a case report of someone getting, I don't know, something with prednisone 10 milligrams for 5 days. It's definitely out there. What's significant? What's the number needed to treat? That's what we try to answer. For corticosteroids, there is no true dichotomy. I think it's actually very rare for me to see patients just getting isolated prednisone now just alone. It's normally in combination with other things, but we have come up with this definition of more than 20 milligrams of prednisone for more than 2 weeks, and that screens out a lot of short-term indications for COPD and things, and I think is pretty handy. Combination immunosuppression is now the norm, not the exception, and that further complicates things. Underlying conditions associated with immunocompromise are extremely relevant. So there's some people who know way more about this than me in the audience, but if you have a splenectomy for a haematological cancer, the consequences in terms of infectious diseases are far higher and much more significant than if that's a splenectomy for trauma, where in fact severe sepsis and death from infection for splenectomy and trauma is very, very rare, so it needs to be treated differently. I really like this idea of looking at the duration and cumulative dose and this concept of the net state of immunosuppression, not just taking one agent or two. This is particularly relevant for complicated haematology oncology patients, but looking at their entire lifetime career of immunosuppression. Then, once you've done all of that, we make a matrix, And the idea of the matrix is, and I've been trying to capture this in the 3 times I've done this chapter, trying to capture the idea that you have like the matrix is the organisms here, like PJP and stuff, and the immunosuppressants here, and it's a matrix. It's actually a 2x2 table, but a matrix is a way more impressive language. But the problem really is that there's now sort of this third dimension, which is the multiple different corticosteroids and other agents. And there's also sort of the disease itself, which is a fourth dimension. And then there's, I guess, local factors. If you live in Darwin, it's quite different to living in Hobart. And so the matrix thing is kind of quite complicated like that. So it's correct. This is, I started going through and trying to actually write what we'd recommended for each of all of these individual new agents. And then decided actually a word cloud would be a much better way of addressing it. You can just see there's this huge further escalation of agents, particularly for non-cancerous conditions in the rheumatological sphere and in neurology now. Neurology's had a massive explosion in agents such as anti-CD20s for multiple sclerosis and that sort of thing. It's very hard to keep up with it, frankly, and I struggle all the time. We have made specific recommendations for a lot of these classes. The only other thing I'd probably say in passing about this is, although we always think this is all new and complicated, some of these agents actually aren't that new now. The JAK inhibitors, for example, have been around for more than 10 years now, and I felt we had much more license to make more certain recommendations of negativity, like certain infections aren't associated with JAK kinase inhibitors, because given 10 years and extremely widespread use, nothing had turned up. So highly targeted biological agents for rheumatological and neurological disease have really exploded on the scene, and it is just a constant challenge to keep up with them. These are good though, right? They really transform patients' lives in a really, really good way and have achieved incredible outcomes for the actual condition, and so I think we've got to really rejoice that these agents are becoming options. There are some specific infections with these agents, so JAK inhibitors and VZV, for example, IL-6 tocilizumab, bacterial sepsis in a particular association with diverticulitis, which we just have seen a case of recently at my hospital, anti-CD20, and the big one is Hep B reactivation, even in people who are surface antigen negative, and again have been involved in some unpleasant medico-legals with that agent in the last couple of years, and things like anakinra reactivating tuberculosis. Probably the biggest single change that's happened for me in my clinical practice is the rise of chimeric antigen receptor therapies. We have a very large haematology oncology unit, and CAR therapies are really taking over now. It's not just CAR T anymore. In fact, if you go to dinner tonight, try not to say CAR T because you sound really uncool. You have to say like CAR therapies now, and don't out yourself as a charlatan. There has been a very big change in the way these are being used, that the B-cell maturation antigen products for multiple myeloma have really, really changed things a lot. The other thing is there's been a stepwise movement up the treatment algorithm from like 4th line, 5th line therapy up the algorithm for multiple myeloma, for B-cell lymphomas and that sort of stuff. So we see them more and more all the time, and these are just coming like a steam train. This shows the increase in CAR therapies in Europe year on year, showing this huge increase, particularly around here when the BCMA therapies became available. As well as causing infectious diseases in themselves, they're often given to people who are already on their 4th line of treatment, so that net burden of immunosuppression already tends to be very high. They also come with these 2 tricky conditions, cytokine release syndrome, or CRS, and immune effector cell-associated neurotoxicity syndrome, or ICANS, which can look very, very much like infections. They're very hard to differentiate and often lead to inappropriate antibiotics and therapies. I don't know how you guys, if you have a CAR therapy unit at your hospital, I guess I'm feeling a bit more confident these days about beginning to label CRS in particular as that, and not giving Mirovank and everything for a week. And we've made, Andrea Hendon was critically helpful in this. We've made some really specific recommendations for a whole lot of infections in CAR therapies for the first time, and I think this is pretty novel and probably the first time we've seen this in Australia. We've delved into recommendations for prevention of infection in solid organ cancers, noting that the EVQ New South Wales cancer treatment guidelines are pretty spectacular and an excellent resource and provide a lot of specific information, but we have provided some more general information to cover over some potential gaps that we saw there, really noting that for most of the infectious diseases indications, solid organ cancers in general, as a general summary, do not require the same level of concern for opportunistic infections as for haematological malignancies. Okay, the big one that I think causes probably more controversy than anything else is antifungal prophylaxis. I've been just constantly amazed why there's so much variation in what's really just not that complicated a question, which is really, should you give posaconazole to people or not? Through so many different units for my whole career, I'm going to come back to that a little bit. Some of the agents we have used in the past, such as voriconazole, come with some big challenges, particularly related to drug-drug interactions, and you'll be very familiar with the vincristine-voriconazole interaction, which can really be quite significantly limiting and may mean that a patient has to receive inferior options for chemotherapy because they can't have that interaction occur. And really, agents that get around that interaction are going to be critical moving forward. I think, again, net immunosuppression to me feels like a really important factor here. I often find the disasters we have these days in the haematology ward are people who have had prolonged disease-related neutropenia prior to them ever receiving immunosuppression. That would account, I think, for most of the breakthrough, most of the mould infections that we see now. We've gone with a number 1 posaconazole recommendation for most scenarios now for mould prophylaxis and fluconazole or echinocandins for yeast prophylaxis. Hep B is just constantly relevant and important, and certainly as I do more and more medico-legal work, a very common reason for clinicians to miss the diagnosis and have to face medico-legal action as a result. I think probably actually my observation on that would be it's often that people have had a Hep B surface antigen test and it's just been buried in the distant past and forgotten about or not acted on. It's actually not necessarily a failure of screening. We and many organisations would recommend that all 3 of a surface antigen, anti-HBC and anti-HBs be performed for everyone undergoing significant immunosuppression, or arguably everyone in Australia once might be also a totally reasonable recommendation. There are some unusual situations where even people who are surface antigen negative still need immunoprophylaxis. That would be for people receiving rituximab, and remember that can take a very long time, like 18 to 24 months to wear off. Alemtuzumab, liver transplants obviously, and other very intensive immunosuppressions. There is a challenge here because this is not a PBS subsidised recommendation, but we have had no trouble funding this through our local drug committee because the drugs are off patent. Something very close to my heart is influenza prophylaxis and the consideration of use of universal oseltamivir. There are recommendations to consider this in the guidelines, but I want to talk about a bit of a local practice that we have been adopting during severe influenza seasons at Royal Brisbane, which seems to be every season now, of providing around 12 weeks of universal oseltamivir for an entire unit when there's a significant outbreak going on. It frankly is very well tolerated and safe and doesn't really have many drug interactions. We and many groups have seen breakthrough infections with this H274Y mutation, which can be associated with oseltamivir resistance, but in fact when that's been studied systematically, these mutations have emerged both in oseltamivir treated and placebo arms at about the same rate. The IDSA guidelines now have a should be administered during an influenza outbreak identified in a long-term care facility or hospital. Our recommendation I don't think was quite as strong as that, and there is also now a second agent, baloxavir, which is now approved as post-exposure prophylaxis as a single dose, would be particularly useful in a sort of a point outbreak. Certainly something to think about. We have had several deaths from influenza transmitted on a haematology ward, but since we implemented this we've had 0, which is great. All right, my final part of my talk, just wrapping up now, is all of the challenges I see with, well, just life at the top level, and then being a doctor, clinical practice, and guideline implementation. No, my life's going fine. I'm going to tell that. Don't worry. The first thing I'd make is infectious diseases, despite all our best efforts, is a field that largely doesn't have any evidence around it, and that's why we all sit in a room and argue about it, because no one actually knows. And one thing for coming onto the therapeutic guidelines is if you have a passionate view about something, try not to be too passionate, because it's almost inevitable that a clinical trial will come and prove you wrong, as it has me numerous times. One other thing I'd also say on top of that is as well as not having a great evidence base, it hasn't really got much better over the last 10 years as well. There haven't actually been that many really impactful clinical trials that can definitively answer questions. I think the problem with that is the kind of evidence we're really looking for is the SNAP studies of the world, these big adaptive platform trials, and there's just only so much they can do, right? They're really hard to do, and there are so many questions. I do think we can firm up some recommendations. There are, I use the example of JAK kinase inhibitors that have been around for actually ages now, and we can get more and more confidence that the evidence, the lack of stuff happening is starting to get more and more reassuring now that this isn't actually an action. And it might be time to start pulling back on some therapeutic interventions that we've done because we're getting more confident with them. And then there's also that constant tension balancing individual outcome versus societal benefit. The classic for this would be giving a fluoroquinolone for prophylaxis in febrile neutropenia whilst driving antimicrobial resistance in gram-negatives and C. diff infections, and the tricky way of basing that. Ranking agents is bordering on impossible, and there are good reasons for why the rankings happen, but they are necessarily really arbitrary because so many of them have never been head-to-head, and you have to trade off toxicities of one sort that seem really important from one class of drugs with another set of toxicities from another class, and there is no really good way of going ahead with that. Trying to keep the chapter to scope is a big challenge. Trying to keep me focused in the meetings and talking about the stuff that's relevant is a bigger challenge, but we'll come back to that. So this chapter doesn't deal with prevention of infection in people with HIV or asplenia because that's dealt with elsewhere in the guidelines. We had an idea that we would only include screening recommendations if it was sort of action required on it. So if you did screening but you kind of didn't really do anything or you just monitored the patient, we wouldn't put that in there. Out of scope, but still important, is prevention in a primary immunodeficiency, relevant in children, but actually increasingly relevant in adults as well. Prevention of infection in chronic diseases that cause immunosuppression, diabetes, chronic kidney disease, and that sort of thing. And all of those very, very important non-pharmaceutical interventions only. Vaccination is beautifully covered in this country in the Australian immunisation guidelines through the federal government. Okay, my particular bugbear, and something that I think is really something we can all really help to address, is the unit-specific guideline recommendation. I have a lot of admiration and respect for the decades of accumulated wisdom that goes into a local specific unit guideline. What I don't love is not sharing that wisdom, subjecting it to peer-to-peer review, trying to work out if there are different guidelines between a Queensland-based transplant unit and a Melbourne-based transplant unit. Why is one better than the other? And really looking at it and trying to evaluate things systematically. Is a transplant patient in Brisbane really that much different to one in Melbourne? Do they really need a different protocol or guideline? I suspect not. To be honest, if this information and data is being generated in the public space, funded by public funds, it's virtually immoral not to release the data and information and share it. And it just is a constant challenge for subspecialty units to have their own little guideline and not be prepared to share that. How can we ever measure and then improve things if we can't even share the information and compare it in the first place? It's just not going to happen. And this is a great challenge for the excellent communicators and young ID physicians we have in the room to take this up. Okay, I must be almost out of time, am I? But I'm going to race through this. My wife is a paediatric emergency physician who is often at work at 3 a.m, and she is the primary source of feedback for therapeutic guidelines and my life, but particularly for guidelines, and really is just very focused on the key question of how do I actually practically find which antibiotic to give to this person at 3 a.m. And I think that's a constant tension with these guidelines as well. That is there too much? Is it too hard to find? I guess it gets at what the purpose of the guidelines are. I just want to know what antibiotic to give. I don't really want to know about the science of anti-CD20A receptors and how they bind to that. Yeah, so I have done my best, and I think the group did really well not to have ranges unless there's a really good reason for it. But honestly, when you're writing guidelines, there's no need to write 2 to 4 milligrams per kilogram or something unless there's just choose 3, honestly. It's not that bad. There's this, again, for the trainees in the room, every antibiotic is always given for 3, 5, 7, 14, 28 or 6 weeks. If you deviate from that even a little, the space-time continuum will collapse and the universe will end. So, and the one I hate the most of all is when it says seek expert advice, and I find this personally embarrassing because that's me, and I don't know, and then I don't know what to do, and I don't know where to seek advice, so... maybe seek even more expert advice or something like that would be good. Another challenge, and this comes up in some of the international guidelines I do as well, is when should a guideline be practically implementable, i.e. the drugs are on the PBS and ready to go and funded, versus when should they be leading the debate. So if there's a great agent out there that's got a New England Journal of Medicine trial behind it, but it just hasn't got TGA or PBS approval yet, how do we incorporate it to the guidelines? I don't know the answer to this, by the way. It's just a constant balance getting that right. We do want to push the boundaries for the best possible outcomes for our patients, but we also want to be practical and useful as well. One thing I don't think we should ever do is censor the guidelines to avoid embarrassment or avoid political stoushes. And in summary, our ageing population is more immunosuppressed than ever before. There are many new therapies targeting different immunological pathways and emerging indications for existing therapies, like CAR therapies. Therapeutic Guidelines has a major expanded chapter about the prevention of infections in immunocompromised. I'm very proud of it. I think it's really useful, and we've really expanded into some really relevant areas that will help a lot for all of you. There are a lot of challenges. There's challenges with lack of evidence, unit-specific guidelines, the balance between being useful to an emergency physician versus providing optimal data-driven science and best patients' outcomes. And I didn't really talk about this, but I think artificial intelligence, we're going to talk about that in the discussion, and that's just there's this huge elephant in the room about everything that we're really going to have to fundamentally rethink how we do this. I would just say very quickly that from an expert contributing to the guidelines, the abilities of some of the deep research options in Gemini and Claude Deep Research do, I think, really have surpassed my ability to do a literature review. Now they're just much more thorough with the new token windows of 1 to 2 million tokens. They can literally hold hundreds of papers in their memory all at once and do it, and I think we're going to have to really think about how to optimise that in the future. Pretty exciting. I think it's going to be a great opportunity, but it has some challenges. And then finally, thank you very much. This was the group. I just cut and pasted this from the website, so I hope this is correct, but this is the group that put this chapter together, chaired by Ingrid Hopper, and many of you are in the room here. It was a really wonderful collaboration, and it felt quite different to some of the earlier ones. I hope you enjoy your time in Hobart here. I was just very finally going to mention that Labrina, which is a restaurant that was in Newtown that's closed down now. It was 24 years ago when I ducked off there during a break. Well, we wagged an afternoon during the conference with my wife, and I proposed, and she said yes. So I got engaged. I got engaged at ASID in Hobart about 20-something years ago now. So there you go. Thank you.
As per scheduled programming, but I just wanted to thank Krispin for that, and also touch on that he brought up a lot of the things that keep me up at night as well. And so I think AI is very interesting, and it's something that people here, I know I am, are thinking a lot about, and how we access trusted clinical information. We would love to hear your thoughts on this, and we'd really like to get some clinicians involved in testing and shaping what's next for therapeutic guidelines. So we've got a booth in the trade hall, which is there. So we'll be here for a few days. Come and have a chinwag. I don't have to be at the booth. You can come to me whenever and have a chat. And I'll hand it back to Leanne to continue chairing.
So much, Krispin. So we do have time for a few questions from the audience. We've got Madeline and Felicia with some roving mics. Does anyone have a question for Krispin? There must be one. I've got one. So Krispin, the scope of the prevention of infection topic has been heavily expanded and now includes regimens for patients who have received solid organ transplants and CAR therapies, not CAR-T. These patients are usually treated in centres with their own guidelines and protocols, as you've mentioned. So who is the target audience of the updated guidance in TG?
That's great. So I think the target audience is all of you, all of the infectious diseases, physicians, microbiologists, AMS pharmacists, ID pharmacists, and the many other people that make this all happen. We were able to consult pretty widely in terms of actually, and one of the big advantages of having lots of non-ID physicians on this time was that people had lots more in reach into colleagues and things. And so I think they are a pretty good broad representation of what's going on, but they of course won't completely coincide with unit-specific guidelines. And I think what would be absolutely awesome in future efforts here is that we start flushing all these out and start moving to a national consensus, because then we can really start measuring it and improving it. So that was the kind of purpose. There is a big expansion in the solid organ, in the stem cell transplant, and particularly in the CAR therapies. And if you're in a hospital that doesn't do that so much, it's probably worth a pretty good read through, because obviously these patients we're just seeing more and more of them, and they're coming to the regional and smaller hospitals all the time now. In fact, many of our patients are managed for an outreach model shortly after the completion of their transplant. So.